Dr. Stephen Pratt, welcome. Welcome to the podcast.
Thank you very much. Just technical question. How I appear on my own screen just changed dramatically. Can you hear me and
Oh,
see me okay?
yeah, I can see you perfectly.
Okay.
What happened on your end?
I've got some like control buttons in front of my face.
Oh, okay. Oh, I see that. Yeah, I don't know how. You might have to just move your mouse away from it or something. Move the pointer
Oh,
away.
there we go. Yep, there we go. That worked.
Okay. Um, okay. Yeah. Don't. That's where I'll trim the beginning.
Yeah.
So, okay. Yeah, Dr. Stephen Pratt, Senior Medical Director at Magellan Health, and you're also a clinician for 25 plus years with experience in treating patients with substance use disorder and overseeing substance use disorder treatment programs. And we're going to be talking today about the Adverse Childhood Experiences study, which I believe was about 25 years ago. And I
Yeah.
read up on it. It looks very interesting. So yeah, tell us a little bit about that study.
Yeah. So the study was conducted through the mid 1990s and published in 1998 by Folletti et al. He worked in the San Diego area. And what the study consisted of was a questionnaire that was sent to, or a survey sent to about 13,000 people who were patients at the clinic where he worked, and they got over 9,000 responses. So a very high response rate. And the survey was asking people about their childhood experiences and adverse childhood experiences across multiple different domains, including physical abuse, sexual abuse, neglect, witnessed domestic violence, the presence of chemical use in the home. And I think there were a total of 7 categories. And so the results really prompted a revolution in behavioral health care, in substance use care, and in healthcare in general, because the findings were so significant. Having a lot of adverse childhood experiences led to poor health choices like smoking, like substance use, and a whole host of health consequences in the physical health realm as well as in the behavioral health realm. And it, as I said, kind of sparked a revolution in the field.
Well, uh, I'm curious about the things that were asked in the questionnaire. Is it possible that a person who in every way seemed to have a perfectly normal, healthy childhood, that maybe there was no drug use or heavy alcohol use in the home, no weapons, no people going to prison, two parents, and everything looks perfect from the outside and maybe even mostly perfect from the inside. Could it be possible that a child in that situation could have a traumatic childhood?
Um, yes. Uh, I think there's a dose response curve in that the greater the amount of adverse childhood experiences, the greater the consequences. But in the 1970s, there was a publication about correctness of fit, was the way they described it. And it was about temperament of the child compared to temperament of the parents. So if you have uh, a child whose temperament is that they're very sensitive, and you have parents whose temperament is that they're very blunt, very just, uh, say it like it is, no holes barred, you didn't do your homework, you can't do this. The child can experience that as traumatic. And rather than having that labeled as any kind of abuse, what the authors of this study um, decided to label it was um, a poor correctness of fit. The temperament of the child and the parents don't match. And so that can lead to some issues in development where the child has some consequences as a result of that.
Yeah. I would think a lot of people can probably relate to that. I'm also curious about how this study may have affected the way that we treat addiction. And I noticed that there's some things that you specialize in or have an interest in, things such as motivational interviewing, which I had learned about in a class and still to this day find a little bit confusing. Trauma-informed care, positive behavior supports. There's another one here, person-centered culture. And I don't know if these things are these things part of what, because from my point of view, we're in an opioid epidemic, and the first thing is, buprenorphine is like really good at getting people off the streets and off opioids and functioning very well. But there, besides that, and maybe including that, what have we changed based on this study?
Yes. So to provide treatment in a trauma-informed manner means that we recognize the impact that that trauma has in people's lives, and we shape the treatment environment to take that into account. Um, for example, um, some healthcare settings have been sort of physically harsh at times. Um, Public mental health centers are often in old buildings with a lot of concrete and things that we can do to soften that environment are helpful. Um, so based on the prevalence of trauma, of adverse childhood experiences that we know from the original ACEs studies and many others that have followed, um, we know that the majority of people have at least some small amount, if not a lot, of adverse childhood experiences of trauma in their past. And so, one of the things that we want to do then is shape our environment to sort of um, anticipate that everyone who comes to see us is potentially traumatized in some ways. There's a concept of universal trauma precautions, which follows from the idea of universal bloodborne pathogen precautions, right? In which we want to make sure that we're not exposing ourselves or the people we serve to the potential of bloodborne pathogens. So we wear gloves when we draw blood, things like that sort. And so the idea of universal trauma precautions means that we want to shape the environment so that there aren't loud, jarring noises, for example, and that there's um, a softness of the environment. There's a softness of the way that people interact. We be respectful, and and not abrasive in the way we talk to people. So all of those things have really been emphasized through the ACEs work and the advent of trauma-informed care.
Uh, yeah, that's incredible, and I think part of what you might be talking about is also related to public health. Making sure that everybody has access to those universal precautions or treatments of not just the person that goes to a private doctor, but someone that goes to a public health clinic, and to get mental health care. And I think that that's definitely important. And everything from obviously you don't want to pop a balloon around someone with a history of trauma, like PTSD or something, and but all the way to like having the right colors and people
Right.
being pleasant, knowing not how to trigger someone or how to avoid triggering someone. So that's really good, and I would think that would also help people to keep them in treatment, because I can see someone walking in for their first treatment, whether it's for Suboxone or for some kind of detox or for some kind of addiction treatment. Maybe they're on methamphetamine or cocaine, and probably their feeling when they walk in the clinic for the first time is, this isn't for me. I'm leaving. I'll come back some other time and try this. And but maybe by following all of those guidelines, there's a better chance that they'll stay for their appointment.
Right, right. A welcoming environment.
Oh, that sounds really good. So so the study was from, it looks like it was from 1994, around that time. I think there
It
was
was
probably over
published
30.
in '98. Yeah.
Okay. So but now, like today, like in addition to the trauma informed treatment of people walking into a clinic and seeing a nice environment and not being triggered in those ways, how is it also affecting our handling of the opioid epidemic and the fentanyl? Some people see the fentanyl problem as being almost more of like a chemical warfare or poisoning. rather than, normal drug use. It's not the same as what we've seen in the past with, um, prescription medication and even heroin. So
Yeah.
how does it apply to today?
Yeah, well, I think one of the concepts that really was a takeaway from that original ACEs study uh, was the idea of self-medication. Now, people talked about this before that study was published, and a lot of people who heard that thought, "Oh, it's making excuses." The idea that self-medicating is the rationale for why people use substances, but when you look at the results of that initial study, what they found was um, something like over 10 times more use of IV drugs in people who had 4 or more categories of ACEs compared to those with none. So, um, so trauma seems to be one of the main triggers for injecting substances. There were also very similar high rates of alcohol use and other illicit drug use, not the same 10 times, but like 7 times more common in people who have these adverse childhood experiences. So, a 1,000% increase in IV drug use, that's that is really telling that that trauma is a factor in people ending up with a substance use issue. And so I think it's changed our conceptualization from, um, going back over years with a lot of other factors coming into play too, from the idea that substance use is a character flaw to substance use is a disorder, is an illness, a behavioral health condition, and that means that we don't approach people like they're making bad choices and they're bad people, but rather that they're in some ways victims, and that we have to address the trauma as well as the addictive behavior if we want to see positive outcomes.
Yeah. How does that relate to the Alcoholics Anonymous and the 12 steps that have been deeply entrenched in addiction treatment for a long time?
Right,
Because it seems like the 12 steps are kind of do put, even though they say, I think, in recovery and those kind of programs that it is a disease, but at the same time, the person has to take responsibility and
right.
work on defects of character and things like that. And it does kind of seem like, you're saying like, well, it's not your fault, but it is kind of your fault. And you have a moral deficiency of some kind. So how
Yeah.
does that play with it?
Yeah, for that, I'll take something that I learned from becoming a DBT therapist many years ago, which is the idea that we would communicate to people in DBT who have a lot of self injurious behavior. It's not your fault that you have these issues, but it's your responsibility to solve them. You know the old joke, how many psychiatrists does it take to change a light bulb? One, but the light bulb has to want to change. I think that's not true because we can influence it with motivational interviewing, but it's a background concept that I think is important to keep in mind. And whether or not it's someone's um, fault, even if it's completely not their fault, no one else can change their attitude, their mindset. We can add tools, we can use tools, we can try to influence, but in the end, the only person who can do the work is the person who has the issues. I mean, that comes down to, it's not just substance use. I mean, think about general health. Let's say that you're obese and you've got high blood pressure and high cholesterol. Yes, you can take medications. Yes, medications can alleviate those symptoms. But if you want to fundamentally change the etiology, it's upon you to make lifestyle changes, to get regular exercise, to eat a healthy diet. And no one else can do that for you.
Yeah. Yeah, that's a good point. Do you think that when a person is in that first stage, that pre-contemplation stage where it seems like nothing works, you just can't convince them, is there actually like a stage where we can't really do anything other than harm reduction? Or can you, like through motivational interviewing or other therapies, can you get to a person even when they seem unreachable?
Yeah. First of all, I think that harm reduction is an essential tool. And there's been historically resistance in the substance use treatment world to that idea. A lot of traditional treatments are abstinence based. I don't think that harm reduction is the end that we necessarily want to get to, but it's a really important tool to use along the way. And then motivational interviewing has strategies to use when someone's in pre-contemplative stage, which is express empathy and roll with resistance. Those are the two key kinds of interventions that we use. If you say something and the response is yes, but, we used to think of that as resistance. In motivational interviewing, they changed the conceptualization of resistance to not something that's intrinsic in this person I'm talking to, but something that has arisen in the context of our interpersonal interaction with them. And so we can't change the way they hear it. We have to change the way we say it. And so as soon as I hear yes, but, or anything that means yes, but, I back up and I think, express empathy. Oh yeah, I can understand that. That would be difficult for you, to to try and think about that change, let alone make it. Um, and so we have to do that over and over and over again. I read in the literature somewhere, I can't remember where, that 90% of people are in the pre-contemplative or contemplative stage of change readiness when they come to us for a new problem. And just think about your own experience when you've come to the point where you think, I have to make a change in my life. That's contemplative, but even so, it takes months before you get to the point of action, right? And
Yeah.
so we have to just over and over again express empathy for how big a challenge it is, roll with resistance when people say that they can't, and then we look for these opportunities where someone is saying their goal is this, but their behavior is leading them in the opposite direction. Um, to say, um, huh, that seems like it conflicts. You said your goal is to do X, but this behavior is going to get you to a goal of Y. How's that going to work for you? And that's in motivational interviewing, they call it creating discrepancy. I like to think of it as identifying discrepancy. We're not creating it, it's there. We're just calling it out. And then the person has to kind of go, huh. Yeah. Often you then get a yes, but, and you go back to expressing empathy. But over the course of multiple sessions, even sometimes months, or in some cases years, the person does get to the point of saying, I have to make this change.
Yeah. Wow. That's yeah. So it's not as far as getting someone to start treatment, start therapy. It's not always going to. In fact, in most cases, like you're saying, 90% probably, we're not going to get someone started right away. Always. Um, and would you agree that the traditional like tough love is probably not a good idea? Like what they might teach in like a Naranon or Al-Anon meeting, like lock the doors and kick them out, or whatever tough love
Yeah.
is.
Right. I don't think that that's a good approach. I mean, kick them out for relapsing when they're in substance use treatment. Um, I think of that as being like someone who's in cancer treatment and they've been in remission and they have a recurrence, and you say, I'm going to kick you out of this cancer clinic because your tumor relapsed. We can't have that. I
Yeah.
think of it as being very similar to that. I wouldn't just throw out the concept of tough love altogether. I would say that there's a really important role of natural consequences. If we interfere with natural consequences and the person doesn't experience negative natural consequences for their behavior, then we're protecting them from an opportunity to be forced to make a change, right? I don't think it's good 99.9% of the time for us to introduce artificial consequences, but to allow natural consequences to have an impact on someone's life and then to help them figure out how to remediate those negative consequences. Huh, this happened to you. So that wasn't good. You didn't like that. What kinds of things could you do differently in the future to see that that doesn't happen again? Often you get it. Nothing. I wasn't doing anything wrong. They just did this to me. Um, and so then you go, yeah, yeah, that's the way it feels, right? That's a bad position to be in. Um, And that's the roll with resistance. And then we keep going over and over again, express empathy, roll with resistance, keep going back to it. But so tough love, I think when we're doing it as some sort of artificial sense, is not a good treatment intervention. But when tough love is allowing natural consequences, that's okay. And that can include things like parents saying to a child, you can't live in my house if you can't follow these rules. If an adult child, um, because if this adult child was renting an apartment and they kept having parties that got the police called, they'd probably get evicted. Parents can do the same thing, and that's a natural consequence. You have to shape it right. You can't be blaming and hostile and aggressive in the way you set that limit with a child, but it's okay to set the limit.
Yeah. Yeah, it's a very difficult problem. It seems like I meet a lot of patients or prospective patients that are at about 40 years old, plus or minus a year or two, and living with their parents, and things are getting worse. And that it's always a difficult decision. You know, do they not allow them to stay in the house, or do they provide other housing, alternate housing for them? Of course, everybody pretty much agrees don't give them money because that's never a good idea. But then when people are given, even when they're given food and other things, they find ways to get money. Um, selling their I think I
Yeah,
had heard a patient was returning her groceries at the grocery store to get the refund money, and I've heard about people buying gas for other people with their parents' credit card and getting cash that way. And
right.
there's just so many difficult ways. And I know I think to an extreme, like if you look at probably what Oregon did, make all the drugs decriminalized in or in Canada, give people all the drugs that they need, and when they're ready, they'll come around. And maybe those to that extreme, it doesn't work so well. Or do you think that could work? I mean, like what they do in British Columbia, like making a lot of things available to people.
Yeah, and they've done similar things in a number of countries. Portugal did that. I think Switzerland, ending the quote unquote war on drugs and replacing it with access, but tied to that access are other things. Like in Portugal, they started this program at least 10 years ago. I can't remember exactly when, but you could get free heroin, pharmaceutical grade heroin, clean needles, but you also had to be enrolled in some sort of a work training program. And so what they found was that, uh, to allow illicit substance use and illegal transactions to be going on means that there's someone who's a drug dealer and that's their business. And when you're in business, one of the keys to success is marketing. First one's free, right? And so now drug dealers are motivated to expand the drug using population so that they're expanding their market and making more money. What they found in Portugal was that idea of providing free pharmaceutical grade heroin, but also requiring um, involvement in some type of rehab, that the number of drug dealers dropped dramatically and the rate of new abusers dropped dramatically.
Oh, wow. Well, that's so so things are working there, but how would you say that do you think that they failed in Oregon, and how would you compare? I mean, was it just a free for all there?
Yeah, I don't have enough familiarity with what went on in Oregon, but I mean, as I was saying on the Portugal example, it has to be
Yeah.
structured right. The structure of it is the key to
Yeah.
success.
That's what I think. I think the difference is I don't know much about it either, other than some headlines and some news reports I saw where
Right.
I think they're backing off on some of the decriminalization of really hard drugs because I don't think it doesn't sound like there was much control of it. Like it was just people using more and more drugs and just out of control,
Yeah.
rampant homelessness and drug use everywhere. Um, but yeah, so as far as going back to the adverse childhood experiences study. How can that should every doctor's office include like a questionnaire or something, or is that something we should standardize, like evaluating people's history of trauma?
I think so. I think so. As I mentioned at the beginning, trauma, adverse childhood experiences has been found to be etiological in health conditions too. Smoking rates, overeating rates, obesity, and all the health consequences, heart disease, cancer, emphysema, all of these um, bad health behaviors, negative health behaviors, and the health consequences of them um, have been influenced by adverse childhood experiences and trauma. And so um, I think the idea of trauma awareness really helps us as an industry be less judgmental and more able to make empathic connections. And empathic
Yeah.
connections are essential to a treatment alliance, to helping people buy into, um, you know, making healthcare changes.
Yeah. Yeah, and there's a lot of, talk discussion on social media of people, identifying as being some kind of an empath, and there's all kinds there's the healing empath and the earth empath, the animal empath, all kinds of different distinctions, and maybe we can, encourage some of these people to use their powers and get into the, substance use disorder treatment, business, maybe even in counseling, and help people with those powers of empathy.
Yeah, there's no one pathway that works for everyone, and so as many tools as we can have available to us, the better we probably are.
Yeah, yeah, it does seem like with, with opioids, we have like these incredible, buprenorphine, I mean, also methadone and naltrexone, and for different people, the medication-assisted treatment works incredibly well. And also for even for alcohol, there's different medications that can help, and naltrexone works incredibly well. And the Canadian Alcohol Use Disorder Society has a long list of medications that people can learn about, doctors can learn about, that in addition to naltrexone even. And but it seems like with there's very limited medication assisted treatment for things like cocaine and methamphetamine,
Right,
and especially when people um, start using multiple things, like they use, like, say, methamphetamine or cocaine or crack along with opioids, then it gets really difficult because it's like if you give them a prescription for Suboxone, they're probably not taking it. And
right.
it's very difficult to get them started. How can we approach that differently?
Yeah. Well, I think the more, as I just said, the more tools we have available to us, the better. I think trying to approach um, substance use with one tool, medication assisted treatment, or there's um, a newer term. It's because they want to de-emphasize the assistance, um,
Yeah,
as sometimes it's primary. Um, Opioid addictions being a clear case where you know replacement therapies or partial replacement therapies seem to be the most effective part of our treatment armamentarium, but across the board, I think we can't take just a single approach and expect to have positive results across the board. We have to have tools that work for the individual. We have to individualize treatment, and the more multifaceted our treatment approach is, the more likely we are to be able to help more people.
yeah. What do you think of artificial intelligence helping out in the therapy world? Because it seems like they just had a demonstration where ChatGPT might be on the verge of being a pretty competent therapist.
Yeah, I'm not familiar enough with that work. I think it's important to get informed, but I just don't know enough to really be able to comment intelligently on that right now.
Okay, yeah, and this is just days ago. They did a demo where ChatGPT can now talk. I mean, the thing that was already like equivalent to a super intelligent human being is now talking, and apparently can pick up your emotions and your feelings and your voice
Mm.
and can respond to
Wow.
that. And I feel like maybe we're not there yet. Maybe it could be months or years away, but I don't think there's enough uh, therapist for everybody. I mean, it's
Right.
people's time is expensive, and there's not enough people trained and willing to help. And I've seen it in movies. In season 3 of Westworld, it opens with that of the one of the main characters talking to his therapist on his Bluetooth ear set, just walking around having long conversations and getting therapy. And it turned out the therapist was an AI that had the voice of one of his army buddies,
Mm.
and it just seems like we're like on the verge of that. So I mean, it could be a breakthrough and rather than getting rid of that A, that assisted part of MAT, the important part where people have someone to talk to and empathize and listen to them and use complex tools like motivational interviewing, maybe we need that kind of help.
Hmm. Yep, I'm always hopeful that we'll have more tools.
Yeah, yeah, definitely, yeah. Yeah, tools, and that's something that I think they do talk a lot about in recovery of, gaining tools, that as you go along, you find the tools that work for you,
Hmm.
and you just keep adding tools to your toolbox, which is a great way of looking at it.
Yeah.
So, Dr. Stephen Pratt, thank you for joining me today.
Thank you very much. I really appreciate the opportunity to talk about these things that I'm passionate about.
Thank you.